Actually, the sub-analysis of Boston study, SVD versus VD, showed that 52 patients who were refractory to Lenalidomide did exceptionally well with Selinexor VD, and a meta-analysis of this cohort showed that patients who received less dose of Selinexor, that it was not in the recommended dose of 100 milligrams once weekly, but in lower dosing, had better results in respect of progression-free survival, overall response rate, and also duration of response. Actually, in this cohort of 52 patients, 35 patients had dose adjustments, and 18 patients had followed the full regimen. And actually, patients that had dose adjustment had a progression-free survival of 13.1 months against 4 months, which was incredible result. And also the adverse events were less, and so we propose that this dose adjustments are very meaningful for this regimen. Also, the main reason that patients don't use Selinexor is the adverse events, like not hematological adverse events, but events of other systems, and usually gastrointestinal adverse events. So it has been shown that when from 100 milligrams, the starting dose would be 60 or 80 milligrams once weekly, these adverse events may fade, and then the patients can stay longer on treatment. I believe that this regimen is a very good one, especially in patients that are triple class refractory, even from the first line of treatment. Now that we use all 3 class regimens up front, and would be every patient would be a perfect candidate for this treatment once the problem with the gastrointestinal adverse events is resolved. Of course, there is also sometimes neutropenia, and also there is thrombocytopenia, mainly due to Velcade, but these are some adverse events that can be easily managed from hematologist side, and also Velcade is also once weekly, which is much better for the patients because they don't experience so much peripheral neuropathy and also thrombocytopenia.